Hello friends, today's talk is on the non-invasive ventilation. Non-invasive ventilation is the provision of the mechanical ventilation without the need of invasive artificial air. NIV can be subdivided into number of modalities with different mechanism of action, including negative pressure ventilation that assists the lung expansion by applying the intermittent negative pressure over the chest and the abdomen. Then positive pressure ventilation that applies the continuous or intermittent positive pressure to upper airway abdominal displacement ventilator like pneumobells and the rocking bed that assist the ventilation at least partly via force of gravity on the abdominal content. Over the past several decades, the non-invasive positive pressure ventilation via nose, mouth or combination has become predominant mode of NIV in both outpatient and hospital setting. Henceforth will be referred as NIV. Now, regarding terminology, as used in this talk, the NIV generic term for number of different non-invasive approaches to assisting ventilation. Whereas the term non-invasive positive pressure ventilation refers specifically to the form that facilitate ventilation by applying positive pressure to the upper air. This can be continuous positive airway pressures, the PAP, that can be used to successfully treat certain form of respiratory failure or intermittent combining positive and expiratory pressure with pressure support ventilation, the latter used to actively assist inspiration. Some ventilators are derived from the portable positive pressure devices to treat sleep apnea and are commonly referred to as bilevel positive airway pressure devices. With this, the term expiratory positive airway pressure is used rather than the PEEP, and inspiratory positive airway pressure refers to the total inspiratory pressure. The difference between IPAP and EPAP equals to the level of the pressure support. Why non-invasive mechanical ventilation? So NIV has more advantage over the invasive mechanical ventilation. By averting the invasion of upper airway, NIV avoids a number of well-known complications of intubation, including expiration of gastric content, dental trauma, trauma to hypopharynx, larynx, and trachea, including tracheal rupture, hypoglossal nerve paralysis, stimulation of autonomic nervous system leading to arrhythmia and hypotension. Ongoing use of invasive ventilation increases the risk of ventilator-associated pneumonia related to the disruption of the airway protective mechanism, pooling of the secretion above the tube cuff that leak into the lower airway, and formation of the bacterial biofilm within the tube that is distributed peripherally during the suction. In addition, irritation from the tube stimulates the mucus secretion and interfere with the normal ciliary function. The need for the repeated suctioning further traumatizes the airway and promotes the bleeding and mucus secretion. Following extubation, immediate complication can include upper airway obstruction due to glottic swelling, negative pressure pulmonary edema, tracheal hemorrhage, and laryngospasm. Complication of prolonged invasive ventilation can include the spectrum of repeated airway and parenchymal infection, vocal cord dysfunction, and tracheal stenosis and malacia. In addition, NIV is better tolerated than the invasive ventilation, requiring less or no sedation. It usually permits short break that help to enhance the tolerance. The avoidance of intubation-associated complication and sedation promotes the more rapid weaning compared to the invasive ventilation, shortening ICU stays and potentially reducing the resource utilization and cost. On the other hand, NIV should not be considered as a replacement for invasive mechanical ventilation. When used appropriately, NIV served as a way to avoid intubation and its attendant complication, but it must be used selectively, avoiding patients who have contraindication. So, appropriate candidate must be able to protect their airway and cooperate. Sometimes NIV is initiated for inappropriate or marginal candidate who fail to respond favorably. In this situation, it is important to intubate promptly, avoiding delays that can lead to unanticipated cardiac pulmonary arrest, necessitating emergency intubation, increased morbidity and mortality. Now, the indication for non-invasive ventilation as determined by the strength of evidence. Supported by strong evidences are COPD exacerbation, COPD failure to wean from invasive mechanical ventilation, and acute cardiogenic pulmonary edema. Other obstructive airway diseases with acute respiratory failure, asthma exacerbation, cystic fibrosis, immunosuppressed patient with acute respiratory failure, hypoxemic respiratory failure like acute lung injury, ARDS, community acquired pneumonia, and trauma. Extubation failure, mainly patients with COPD and congestive heart failure, post-operative respiratory failure, prophylactic use of CPAP and BiPAP after high-risk surgery, treatment of acute respiratory failure, mainly COPD and congestive heart failure. Do not intubate patient to treat acute respiratory failure and to palliate for relief of dyspnea and to extend survival to settle affair. Then obesity, hypoventilation, neuromuscular disease, and partial upper airway obstruction. And it is not recommended in acute lung injury, ARDS with multi-organ system dysfunction, hypotensive shock, end-stage pulmonary fibrosis with exacerbation, total or near total upper airway obstruction. So selection guidelines for the NIV in acute respiratory failure. Selection of appropriate patient for NIV is critical for optimizing success and providing benefit. Knowledge of the factor that predict the success or failure is helpful in predicting good candidate for NIV. In fact, predictors indicate that the patient who are most likely to succeed with NIV have incipient milder respiratory failure than those who fail. So this is the predictor score for the NIV. So inability to cooperate with therapy or GCS score less than 12, respiratory rate more than 30 or hypoxemia, severe dyspnea, excessive accessory muscle or paradoxical breathing, then this hypercapnic respiratory failure with acidemia, that is pH less than 7.1. Then acute hypoxemic respiratory failure with PO2 FiO2 less than 100. Then this SAP score more than 34, Apache score more than 29, age more than 40 or less than 70, bicarb less than 22, multi-organ dysfunction, ARDS pneumonia, especially with high tidal volume, lack of improvement in the respiratory rate within the 1 to 2 hours, lack of increase in PO2 FiO2 of more than 175 within 1 hour. Then selection process. This is the simple three-step process. First of which is to establish that the patient has favorable diagnosis. Ideally, a condition like cardiogenic pulmonary edema or COPD, which is likely to respond to medical therapy fairly rapidly. Then patient with the weaker indications like asthma, pneumonia can be tried on NIV but must be monitored very closely in ICU, especially if they have risk factor for NIV failure. Now, the patient with very high risk factor for NIV failure, such as those with sepsis and evolving multi-organ dysfunction, are generally best managed invasively rather than to delay needed intubation. Then the step two is to identify patients who need the ventilatory assistance so that the modality is not wasted on patients who are too mildly ill to warrant ventilatory assistance. This is done on the basis of simple bedside observation of dyspnea, vital sign, and evidence of increased work of breathing, such as vigorous accessory muscle use. Arterial blood gas results showing acute and chronic CO2 retention may be helpful, but needed ventilatory assistance should not be delayed pending availability of the blood gas results. Third step is to exclude the patient who have contraindication to NIV and should be managed invasively. Most of the contraindication are relative and judgment must be exercised when deciding whether the patient have excessive secretion, medical instability, and uncooperative. Coma and severe obtundation are not considered absolute contraindication as long as they are related to hypercapnia. Patients with the hypercapnic coma have success and survival rate with NIV that are equivalent to those with similar non-comatose patients. Now, regarding contraindication of NIV, cardiac arrest or respiratory arrest, then medically unstable patient like those who in hypotensive shock, uncontrolled cardiac ischemia, arrhythmia, severe upper GI bleeding and unable to protect airway like impaired cough or swelling. Then excessive secretion, unable to apply mask during facial surgery, trauma, burns, facial deformity, if the patient is agitated or uncooperative, then untrained pneumothorax and multi-organ system failure. Then the techniques and equipment for NIV. Interface, that is nasal mask. Nasal masks are the most commonly used interfaces for outpatient with the chronic respiratory failure because they are comfortable than nasal prongs or oronasal masks, even if they are less efficient than the oronasal mask at eliminating CO2. In addition, they permit speech and expectoration, and with some practice, eating during the use. Manufacturers offers numerous modification of nasal masks that fit into several basic categories. Then standard nasal masks. Standard nasal masks were the first designed during early 1980s to provide CPAP for obstructive sleep apnea and consist of triangular clear plastic domes that fit over the nose. A soft, usually silicone cuff makes contact with the skin around the perimeter of the nose to form the air seal. This mask must be fit properly to minimize pressure over the bridge of the nose, which may include redness, skin irritation, and occasionally ulceration. Forehead spacers are an adjustable joint, often used to minimize pressure on the bridge of the nose. Various approaches have been used to enhance the patient comfort, including additional thin plastic flap or baffle system to further reduce the strap tension necessary to maintain airflow. Gel containing seals, some of that have heat molding capabilities, may help even distribute the pressure of the seal around the face. Then nasal pillows and the cradle. Nasal pillows consist of the small rubber cone that are inserted directly into nostril, and nasal cradles are similar but replace the rubber cone with thin silicone membrane with perforation that allows the pressurized gas to enter the nostril. By removing the sealing surface from the eyes, this reduces the claustrophobia and permit the use of the eyeglasses. They also eliminate contact with the nasal bridge and are helpful for patients with nasal bridge irritation and ulceration caused by standard nasal masks. However, they can cause irritation of the nostril and some patients alternate between different type of the mask as a way of minimizing discomfort. Nasal pillow and cradles are less often used in the acute care setting because they tend to leak more air at high pressures. Oronasal and full face masks. The main advantage of oronasal over the nasal mask is that they reduces the air leaking through the mouth because they cover both nose and the mouth. Mainly because of this advantage, the Koch et al. Found that oronasal was significantly better tolerated than the nasal mask in acute setting. Air seal of oronasal mask are similar to those of the nasal mask, using the thin membrane of soft silicone to enhance comfort and minimizing air leak. Oronasal masks have the built-in valve to prevent breathing and aspiration in the event of ventilator malfunction, especially for bi-level ventilator. Because of the concern that vomiting into oronasal mask could cause aspiration, these masks have straps that allow the rapid removal. Some oronasal masks incorporate shelf that fits under the chin to stabilize it, aiming to minimize air leaking under the seat. Comparing the nasal mask, oronasal mask interfere more with the speech eating and have more dead space and less comfortable. However, because of their better initial tolerability and more efficient CO2 removal than the nasal mask, they are usually preferred to treat acute respiratory failure. The total face mask is the large version of the oronasal mask that seal over forehead and under the chin, resembling the snorkeling mask. It moves the sealing surface away from the nose and mouth and eliminates the mask leakage into the eyes. Most patients find it comfortable and no more claustrophobic than the standard oronasal mask. Two small RCTs comparing total face mask to the standard oronasal mask found no difference of outcome between the masks. But one found that the total face mask was better tolerated and suggested that it could serve as alternative for patients intolerant to the standard full face mask. Then the next device is helmet. Helmet that have been used and studied primarily in the Italy and have not yet been formally approved for the use with NIV in United States, although several type of the helmet received as the emergency use authorization for COVID-19 pandemic. They consist of the pliable, transparent plastic cylinder that fit over the head and seal around the neck and shoulder, sometimes secured by the strap under axle. Some studies evaluating its use for the COPD patient shows that it is more comfortable and reduces facial ulceration compared with oronasal mask. But recent RCT showed the equivalent responses and tolerance between the helmet and full face mask, except the mask lowered the dyspnea score more rapidly. In another recent RCT on patient with ARDS, helmet avoided intubation and reduces the mortality compared to the standard full mask. To prevent the rebreathing, high airflow rate are necessary, which render the helmet much noisier than the oropharal mask. Although helmet has some potential advantage over the full face mask, they may be efficacious than full face mask for ARDS patient. It is also noisier, costlier, and unavailable. Nonetheless, it has the advantage of avoiding contact over nose and mouth and may serve as useful alternative when patients are having trouble tolerating other masks. Although during pandemic it was considered less apt to disperse aerosol, although the probably depend upon the manufacturer because some neck seals air leak. Now the oral interfaces. Oral interfaces consist of mouthpiece inserted into the lip seal that is strapped tightly around the head to minimize the air leakage have been used to treat patients with the chronic neuromuscular condition for many decades. A commercially available oral interface was introduced more recently for treatment of occasional patients with sleep apnea. These interfaces are not often used in the acute care setting, although some studies have had patients hold interface in their mouth to enhance their sense of control when initiating an. Now the next is headgear. The strap used to hold interface in the place are important for interface comfort and stability as well as for control of air leak. The number of strap connection varies from the 2 to 5 depending upon the mask. In general, the more connection, the more stable the interface. But discomfort and claustrophobia becomes concern. Most straps are soft, elastic material fastened with Velcro, but abrasion can occur if edges are too rough. Minimizing the strap tension just to the point of controlling air leak is important to optimize the comfort. Now, the ventilator from NIV, the microprocessor control ventilator are currently used mainly for invasive mechanical ventilation critical care unit that can be adapted for the NIV. This offers array of volume limited and pressure limited mode and sophisticated monitoring and alarm capabilities. Advantage over bilevel positive pressure devices include universal presence of O2 blenders, accurate tracking of the tidal and minute volume, dual limb circuit with active exhalation valve that minimizes the rebreathing. Most practitioner uses the pressure support mode of the NIV with ventilator because of enhance the comfort combining it with TP. Shortcoming of the ventilator when used to deliver NIV include intolerance of air leak that inevitably occur with NIV, causing difficulty with triggering and cycling, which set off the annoying alarm. Most critical care ventilator now incorporate NIV mode that automatically improve leak tolerance and compensating abilities. Disable nuisance alarm and permit the multiple adjustment, including those to limit inspiratory time, thus enabling improved expiratory synchron. These modes have undergone little evaluation clinical setting, but when studies demonstrated that most NIV modes of the critical care ventilator work well to deliver set pressure and volume, unless there are large air leak, in which case most of them require additional adjustment to maintain delivery. One of the studies also examined the synchrony of ventilated patient in crossover study and found that NIV dedicated ventilator synchronized slightly better than the critical care and transport ventilators using NIV mode. Mask and the circuitry for application of NIV via critical care ventilator should not have built-in exhalation valve designed for use with single circuit bi-level devices because this will increase air leaking and interfere with the proper function. Some mask malfunction use the blue coloration for plastic part of the mask meant for use with the critical ventilator so that they can be easily identified. Now the next is BiPAP. These devices were first conceived to enhance the comfort for patients requiring high CPAP to treat sleep apnea, but it rapidly became apparent when they function as pressure support ventilators as well. By virtue of their air leak tolerance and algorithm to enhance synchrony in the face of leak, bi-level ventilator that deliver pressure assist or pressure support ventilation are most commonly used ventilator today for delivering NI. The proto-bival device was the BiPAP ST, introduced during late 1980s, but numerous versions are now available from manufacturers. Bi-level devices deliver two levels of positive pressure, preset IPAP and EPAP. The difference between the two is the level of inspiratory assistance or pressure support. Pressure support mode provides sensitive inspiratory triggering and expiratory cycling mechanism, permitting excellent patient ventilator synchrony, reducing diaphragmatic work, and improving pressure comfort. Bi-level devices designed for the home use are lighter and more compact. The V60 was designed for the both invasive and non-invasive acute care application, although used mainly for the non-invasive. Equipped with the O2 blender, it can provide high FiO2 and has more sophisticated alarm and monitoring system than home-based bi-level device. It also features the adjustable rise time and inspiratory time limit that can help with comfort and synchrony. Because of this feature, it is popular choice for administration of NIV in acute care setting. The V60 also incorporate battery backup for transport if needed. Because they have single ventilator circuitry, breathing can occur during the use of bi-level ventilator and can interfere with the ability to enhance CO2 elimination. The rebreathing can be minimized by using mask with the in-mask exhalation port, which are associated with the less rebreathing than in-circuit valve. Use of the non-breathing valve. EPAP pressure of 4 centimeter or higher, which ensures the higher bias flow during the exhalation. Now, adjunct to NIV, humidification may enhance comfort during NIV and it's advised when NIV is to be used for more than few hours. For acute care setting, heated humidifier is preferred over heat and moisture exchange because later add to work of breathing and may interfere with the triggering and cycling. Also, with excessive airway leakage, the heated humidifier lowers the nasal resistance. Nasogastric tube are not routinely recommended as an adjunct to NIV when oronasal masks are used, but small pore flexible nasogastric tube can be used for feeding when necessary and do not interfere much with the masking. Then regarding ventilator mode, although pressure support is the most commonly chosen mode to deliver NIV, other might be considered. Like average volume assured pressure support is available on the V60 bi-level device. It tracks the recent delivered tidal volume and automatically adjusts the inspiratory pressure to achieve the target minute volume. That is 8 ml per kg of ideal body weight. Then intelligent volume assured support is similar to AVAPs but target alveolar volume as determined by subtracting anatomical space from the ideal tidal volume and multiplying by respiratory rate. This mode can lower the PaCO2 more rapidly than the bi-level positive airway pressure in hypoventilating patient, as has been shown for AVAPs in obesity, hypoventilation, but no other efficacy advantages over other standard BiPAP has been shown for acute care setting. Neurally adjusted ventilator assistant uses the diaphragm electromyographic signal detected by esophageal electrode to determine ventilatory assistance. Administered non-invasively, it improves synchrony compared to the pressure support, but without greater improvement in gas exchange or comfort. Then regarding initiation of NIV, NIV is most often begin in the emergency department or ICU for acutely dyspneic patients who can become panicky when masks are strapped to their faces. Thus, unlike initiation of the invasive ventilation with the patient heavily sedated or even paralyzed, initiation of NIV requires skill on the part of caregiver to rapidly gain confidence of the patient and help them cooperate so that they can benefit from the technique. Explaining clearly what is happening and what is to expect using verbal cues like try to let the ventilator breathe for you and giving the patient control by allowing them to hold mask on their face can be quite helpful. Proper mask fit should be assured and the mask attached to the ventilator via tubing. Most practitioners start with the pressure support ventilation using relatively low pressure ventilator pressures, that is 8 to 10 centimeter of water for IPAP and 4 to 5 centimeter of water for EPAP for at least several minutes to allow the patient to become familiar with the mask and the airflow. It is then extremely important to increase the inspiratory pressure and thereby the level of the pressure support to reduce the respiratory distress and the effort. Targeting the respiratory rate in the low 20 per minute and increasing the tidal volume to 6 to 7 ml per kg. Patients are often intolerant of high pressure, especially initially, because of the sensation of the burning in the sinuses or pressure in the air, or because of the perceived effort of the exhaling against the elevated pressure. Thus, adjustment of inspiratory pressure become titration and tailored for individual patient, balancing the relief of the respiratory distress and attainment of the ventilatory target against the intolerance due to excessive pressures. Expiratory pressure is usually kept at 4 to 5 but can be adjusted upward for patients who have difficulty triggering due to intrinsic peak. Upper airway obstruction due to sleep apnea or hypoxemia, despite increase in FiO2 to above 50 to 50% to 60%. Leher et al. Demonstrated that for patients with the acute lung injury, increases of PEEP during NIV were quite effective for improving oxygenation, and increases of pressure support are effective for relieving dyspnea. However, it is well to recall that EPAP is increased during NIV and IPAP must also be increased by same amount to maintain the level of pressure support and tidal volume. Now regarding monitoring, because the location of the non-invasive ventilation, because of the importance of prompt initiation to avoid further patient deterioration that could necessitate intubation, NIV should be started wherever the patient comes to medical attention as long as the appropriate equipment and personnel are available. Once initiated, transfer to the appropriate monitored location becomes important. This depends upon the patient need for monitoring as well as the patient's monitoring capability and skill of the staff for managing NIV. Assessment of the patient need for monitoring include consideration of the severity of respiratory failure as well as any comorbidity. When in doubt, brief trial of NIV withdrawal may be helpful. In one study of the patient treated with NIV in the ED for acute pulmonary edema COPD, patient who remained stable during 15 minutes of discontinuation, trial were transferred to regular ward and none subsequently require intubation. NIV is used on the regular ward for of many hospitals because of the scarcity of ICU bed, but some guidelines have recommended that NIV be applied only in the ICU because of concern about the patient safety. With proper training and the availability of the support personnel, NIV can be administered safely on regular floors for selected patients. Now, what to monitor exactly when the patient is on NIV? So, subject to response like comfort, mask related, airway pressure, and the flow related, then dyspnea, claustrophobia, agitation, delirium, then vital signs like respiratory rate, heart rate, blood pressure, Then breathing efforts like accessory muscle use, paradoxical breathing, then gas exchange like continuous oximetry, then baseline and 1 to 2 hour ABG that's indicated, then synchrony like triggering and expiratory asynchrony, then air leaks like mask leak through mouth and with nasal mask. Then see for the secretion clearance, like whether the patient is able to cough or not, or whether he is producing good amount of secretion is not. Then regarding the complication and side effect of NIV, uh, the mask, if it is interface related, then check size and the fit. Readjust the headgear. Then if patient is complaining of discomfort, then they try different masks. If there is skin ulceration, then readjust the mask or loosen the strap. Then air pressure and the flow related complication, nasal sinus pain and dryness, low pressure temporary humidify gas and nasal saline. If it is conjunctivitis, then reset mask, check seal on the nasal bridge, artificial skin, and consider new mask type. If there is a gastric distension, then the lower pressure if possible. Observe for distension and consider nasogastric drainage. If there is patient ventilator asynchrony, then eliminate leak, treat agitation, assess for discomfort, try lowering pressure support or limiting inspiratory time. If rebreathing, in case of rebreathing, use the mask within mask exhalation valve, use adequate EPAP, use ventilator with active exhalation valve. Air leak, reset, readjust strap, try different mask type, change strap if nasal mask, and lower pressure if possible. Then caregiver related complication, inadequate or excessive pressure, monitor more safely, carefully, adjust upward as tolerance, then assure adequate training. Inadequate equipment, initiate NPPV program with full selection mix. And then regarding patient related agitation, anxiety, if patient is agitated and anxious, then assure proper mask fit, ventilatory setting, reassure and consider sedation. Then regarding sedation and analgesia during NIV, judicious use of sedation may help to calm patient and having difficulty cooperating with NIV. But most clinicians are very cautious using small dose, mainly by intermittent bolus than what they use in the invasive ventilated patient. Most respond to the survey of critical care physicians from North America and Europe indicated that they use sedation and analgesia in less than 25% of the patient. They registered concern about the blunting the drive to breath of spontaneously breathing patient. North America were more apt to use benzodiazepine alone and European opioid alone as the preferred initial choice. Dexmedetomidine, by virtue of its short duration of action, intravenous administration allowing rapid adjustment of effect, analgesic as well as sedation property, and lack of the respiratory depression effect, has been considered as an attractive agent for use with the NIV. In an RCT, David et al. Showed no benefit of dexmedetomidine compared to the standard intermittent benzodiazepine and opioid when started routinely at initiation of NIV. However, in another RCT, Hung et al. Showed reduced intubation and shorter length of hospital stay in study of patient with cardiogenic pulmonary edema, failing NIV due to intolerance or agitation. More recent meta-analysis and systemic review showed that dexmedetomidine lead to the reduction in the delirium and need for the mechanical ventilation in acutely ill adult who required NIV, although there was increased risk of bradycardia and hypotension. In Europe, remifentanil use was also associated with the reduced need for intubation for small cohort of patients failing NIV. These observations suggest that the short-acting infusion medication may have advantages as rescue agent or in carefully selected patients, but have no role as agent to be used routinely at the time of initiation of NIV. More information from clinical studies is needed before recommendation for specific medication and doses can be made, but the use of sedation and analgesia should be considered for patient at risk of failing NIV because of agitation, apprehension, or discomfort. Thank you, guys.